We'll be taking on both of the CA LARYNX cavity today, and we'll be discussing it in the similar format as we discussed the our CM's commerce type. Okay, like we'll be going in a case-based scenario, and all the requisite or possible questions that might be asked from that topic, we'll write it down there itself and kill the issue there only. And what all possible topics from which questions can be asked, that also we'll see along with it, so that like while doing your revisions for your main practicals, you will have them handy. Okay, so let's start. Okay, let's go with CL larynx first. Okay, chalo, please bear with me today. I'll try that it shouldn't cross the 1 hour mark. ठीक है, अगर थोड़ा बहुत क्रॉस होता है तो I'll take my apologies. Okay, so let's start. Mr. Okay. See, Mr. Gaurav, aged. So and so, like you can start with 50 years old male, profession, so and so, resident of so and so, came with complaints of. Okay, so all the possible complaints with which the larynx patient that might present to you or that you'll say in the exam, we'll be discussing it not from the point of knowledge per se, only from the point of exam practical points per se. Okay, so what all he can present to you is dysphonia. He'll present to you with dysphagia or odynophagia, or he might present to you with sensation of globus. What is globus? Globus means that feeling of something stuck in the throat. Okay. For this presentation, what all I have undergone, that is, one is the routine presentations, that is by the NB, that I have taken the reference 1. Second is the traditional study material which we all have, uska questions include kiya hai 2, and number 3 is the classes by the TMC जो अपना super specialty के classes हैं, lectures का, that questions also I have tried to include in this. Okay, so most of them is being covered. The only thing is you have to remember it. Okay, and try to correlate it. Okay, so the possible questions which can arise over here is like coming to this thing, dysphonia. This basically suggests the involvement of glottis, and therefore it presents to us earlier. And when it's presented to us earlier, okay, when it's presented to us earlier, so its management is earlier, and therefore its prognosis is better. Prognosis is better. Dysphagia, basically, it can be anything, mostly your supraglottis, subglottis, okay, and presents little bit late, so therefore the like treatment per se, jo prognosis hai, that is poorer. So over here, the question generally asked is which type of malignancies will present to you earlier, which type of malignancy will have better prognosis. Over here, the question box, one is subsides of larynx. Okay. So if examiner goes into the anatomical details, he will ask you what are the details of your supraglottis. So that you have to mention 1, 2, 3. Glottis, so you have to mention PVC, false vocal cord, and same goes for the subglottis. Just a minute, guys. There is a procession going outside, because of which a lot of noise disturbance is there. Sure. We'll continue. In the history of present illness, you can bring about 2 things. One is that the patient was initially having this difficulty of dysphagia to solids more than liquids, or as the case may be, the only positive finding the only thing is that in the solids, gate बंद करता हूँ. if the patient is having this difficulty more towards solids, it indicates some of the obstructive reason. Whereas towards if the patient is having dysphagia more of liquids, it suggests more of some neuromuscular disorder. Okay, so what all we have to bring about over here is the standard format, that the patient is having dysphagia, which is both to solids or liquids, which is more in solids and more in liquids, जो भी आपके case में हो, which was initially around 6 months back and has progressed to the present condition. Apart from that, what else can he say? That he's having history of hoarseness of voice. Now, in hoarseness of voice, you'll tell the duration. That sir, he's having this problem from last say 2 months, 3 months, 6 months. Over here only, in the negative history, wherever you want, you can bring out 2 points, that there is no history of voice abuse. This can also be the case in the he might ask you कि ये क्यों पूछा आपने, ठीक है? So this can be the case in the profession, like people who are having this profession of speaking, like police people, traffic people, teachers, musicians. So they might have this hoarseness of voice, which can be due to some benign reasons, such as the vocal polyp, vocal nodule, Rinke's edema, all those type of things. And second thing is there is no history of any diurnal variation. Diurnal variation of voice will be present in the patients of laryngitis, okay, in the patients of LPR. So that is again going more towards the benign pathology. So apart from that, what else you can tell to the examiner is, so there is history of, or there is no history of odynophagia, hemoptysis, whether it's there or not, okay? Whether there is any neck mass. Neck, never forget, okay? Don't forget neck. Koi bhi, whatever long case you have been given, please don't forget neck. ENT mein neck you have to examine, okay? So what all you have to see over here, any mets, any cups, okay, or any lymph nodes which is presented to us, and there is no history of any ear pain. So all these things rule out your basically कि malignancy का mets है कि नहीं है, okay? So referred otalgia you have to rule out, and whether there is any history of weight loss.
Sir,
so like हाँ बताइए.
Sir, can we ask history of intubation in this negative history itself in HOPI?
You can give it, but it's better to like intubation को आप जो आपका past history or treatment history है ना, वहाँ पे if you will bring it out, so that will be better. Like intubation will be for some particular illness, okay? So that illness will be better if you will bring it in past history. जहाँ पे हम बोलते हैं कि sir there is no previous medical or surgical illness, वहाँ पे you can bring it out कि sir he is a known patient of so and so for which intubation was done, okay? You can bring it here also, ऐसा there is no hard and fast rule. But like उसका जो section है वहाँ पे if you bring it out, that's better, okay? So one question that will be asked over here is, you can be stopped over here. Doctor, please stop and tell me what is your initial impression by the history till now and why. So over here, what all possibilities can come is that first of all, whether the malignancy, why is it not thyroid? जो एक वहाँ पे तुरंत question उठता है कि why do you say it's not thyroid? So thyroid, whatever cases are there, commonly they'll start with some type of swelling in the neck rather than dysphagia, odynophagia, hoarseness of voice, okay? So we all are versed with this thing, like in case of very heavy goiter, very big goiter, all these things can cause retrosternal extension. वहाँ पे जा करके आपको dysphagia and ये symptoms होंगे, but the initial presentation of patient with this thing is quite rare. Okay, so from these things, the thyroid is generally ruled out. It's not of a thyroid. It should not be a thyroid. Likely not a thyroid. More going towards the larynx. In the larynx, then again, same thing: subglottis, supraglottis, or glottis. So that we have already discussed. Please remember what are the subsites. You have to learn them. You can't afford to forget them. Okay. So coming to past history. So over here, the patient is a known case of. Example XYZ, whatever you want to answer. We'll in our setting, the patient is a known case of COPD, whether there is any hypertension or diabetes, whether there is any history of tuberculosis. That's very important to be brought out in our patient. Why? This we will discuss. कि जो इसका treatment होगा, larynx का जो treatment होगा, उसमें like mostly what we follow is where our most of the questions of exam will be focused is the total laryngectomy. Okay, so over here we have to see whether the patient has that pulmonary reserve or not. So these things becomes important in patients of COPD and tuberculosis. Acha, one more point, Dr. Akash, you were telling about intubation. So in what scenario would you like to take this history? Like what were you thinking? What point? Can you please elaborate?
Sir, I was thinking in regards to dysphonia, where the patient will present with change in voice, and with patients of intubation, there can be intubation granuloma. So that is why I was.
Yeah, definitely. So that you can bring it out. That if you are thinking on those grounds, likely speaking, you have to think on those grounds कि हमको exam में answer करना है ना? So it's very unlikely कि you will get this kind of patient, that intubation granuloma, which are more common on the posterior aspects or all. कि these things that we get in the main exam, it's highly unlikely. Na? So you can add this point, sir, there is no history of intubation, and you can use it as your one-liner, and you might give it a pause and wait for the examiner to ask, Doctor sir, why did you take this history of intubation? So then you can bring it out. Okay.
Yes, sir.
ठीक है, तो इसके बाद आगे चलते हैं. ठीक है, so over here again one of the very important question is what is field cancerization and who gave it? Dr. Sahab, it's very important. I think many times we have discussed it, given by Slaughter et al. We all remember it. We will discuss it again when we'll be going through this oral cavity session. Slaughter and et al. And it most commonly, I'll give you the gist of this thing, is that the whole aerodigestive tract is exposed to the same kind of carcinogen. Okay, so therefore it's not that कि एक ही जगह पे malignancy हुआ है वहीं पे उसका असर खत्म हो जाएगा. It's not that. When the whole mucosa is exposed to that same carcinogen, there is possibility of having the cancer in the similar aerodigestive tract elsewhere also. Okay, so this is the gist of field cancerization. Slaughter et al. Is also called as Slaughter's hypothesis. It's important. Okay, please go through it. Okay, so why is smoking important? Okay, so why is it important? Smoking में what all you can say is, one, what all carcinogens are there? ठीक है, this list is included in the oral cavity PDF, which will be just shared in a while. You shouldn't stop just at nicotine. Nicotine सबको पता होता है. After nicotine, you should be able to answer कि sir, these kind of nitrosamines, aldehyde, formaldehydes, all these things are associated, which are all carcinogens. ठीक है, so that you should be able to answer. One. Second thing is, there is whole a flow chart that how smoking causes cancer. I'll share that article in the we'll be sharing it soon. Okay, so please go through it. So if your examiner asks you, you'll be able to tell it point wise, or if you have read it from your own theory, that's well and good. Okay, and third thing is this thing. Now I'll request one of you to again unmute. What is the importance of smoking and alcohol together? Why is it more dangerous? Can somebody try and take a synergistic effect? So this is one main answer that you have to answer, synergistic effect. But पूरा उसका 5-6 points का एक table है, ठीक है, which is given in.
Acts as a solvent for other carcinogens.
Exactly. So after saying that this is a synergistic thing, you should be ready with all these things, that it acts as a solvent for your carcinogens to dissolve. Then the product of this alcohol itself is जो aldehyde बनता है, that aldehyde itself is toxic compound which causes multiple problems. Then there's something related to cytochrome also. Number 4 is that generally a person who is taking lots and lots of alcohol is also deficient in multiple vitamins. So again, making that person prone to various other issues. Okay, so that we'll be sharing. Go through it. And over here only there will be one more thing. यहाँ पे जो flow chart है, यहाँ पे there is a methylation pathway which is there. So basically, this is more of a theoretical thing, why these things are caused. So we'll just take care of them. Coming to the next question, what are familial malignancies? जब आप family history बोलेंगे, if there is no history of similar things in the family, so there will be one question which might come out. What are the familial malignancies that you know about? So can somebody again take a try? 2-3 नाम. Fanconi's anemia. I'll just write it over here. Okay, so please help me out. One is Fanconi's anemia. This data is from Scott Brown itself. Okay. Second is anybody else? एक और try.
Bloom's telangiectasia.
Bloom's syndrome, ataxia telangiectasia. ठीक है. And इसके आगे I am also forgetting. ठीक है. कहाँ ये this Cowden's and ये Gardner's भी है आपका. And this xeroderma pigmentosa also is there. Okay, so वो भी screenshot उसमें लगाया हुआ. Basically, what I have done is all the important screenshots from Scott Brown, Cummings, and Stellenmarin. I have just taken it and pasted it at appropriate places. Okay, so these are more on that oral cavity sections. ये larynx में ये चीजें कम थी. Okay, over here only 3 points I would like to mention to you in the Ratnagiri belt. Okay, so in these places people use tobacco paste. Okay, in certain regions of Maharashtra, UP and Bihar, there is a this thing comes by the name of Mishri. The people who are working in those regions will relate to thing. This kind of tobacco which they use is by the name of Mishri. Okay, so ये भी लगाते हैं कि like in our center, like not in our center, the place I belong, Mishri is the name of sugar coating, like sugar का एक form होता है. So the first time when I heard कि why is he asking this history of Mishri, then I came to the उधर पे ऐसा करके some tobacco form is also what they use. Okay, एक हो गया, दो हो गया. Pipe smoking. Why is pipe smoking important to us? In which kind of cancer is it important?
Palate.
हाँ. Palate नीचे वाला है. Pipe smoking is for lip cancer. ठीक है. Reverse smoking is for your palatal cancer. Basically for hard palate. Okay. Lip cancer जब भी आप पढ़ेंगे question box. Lip के recon के लिए there are multiple flaps which they are using. So images are there in Scott Brown, which have been shared also. Please go through them once again. I think around 4 to 5 images are there. Okay, please revise it multiple number of times. What is Abbey sustainable flap? Okay, ये पूरा जो section है, please go through it. Burrow flap कहाँ बना रहे हैं? That images should be clear in your mind. Okay, so over here, after reverse smoking, what all can come is okay, done. Okay, over here, till this you will be able to ask to summarize your case. Based on your history, what are you thinking? So similarly, as we did in your squamous, on similar kind, based on history, you'll say, sir, 26, not 26, whatever age of the patient is there, this much year old male patient came with complaints of dysphagia since 6 months duration, which was initially to solid and now progressed to more also to liquids also. And apart from that, the patient is not having any dysphonia or any other neck swelling. यहाँ तक आप history में बोल सकते हैं. Generally what happens is कि examiner will ask you कि doctor साहब tell me what is the case, what is the summary, and how will you manage the case. This is how the things generally start, leaving apart the initial 2-3 candidates जिनसे शुरू होता है viva, उसमें तो पूरा detailed things will go. After that it's like you tell me what are the positive findings in your patient and why are you saying so, what is your diagnosis, how will you support your diagnosis, and how will you manage it. So it starts from this thing only, and then whatever you will speak, the viva will go on the same thing. Okay, so that's why viva is, examiner is same for everybody, but viva becomes different. So generally people ask on whatever you are saying. Okay, so speak very carefully whatever you are answering. Okay, so on examination, so it again starts from that same thing. General condition is fair. BP is so and so, pulse is so and so. Please again same thing. अगर sphygmomanometer नहीं है तो BP नहीं बोलना है. You have to tell, sir, I would like to see BP, but since the apparatus was not there, so I have not seen it. Over here, one thing is more that BMI is important. Why BMI is important? Because in the patients of malignancy, you have to look on their BMI also, and depending upon this, the treatment things will change. So whenever a patient is subjected to radiotherapy and chemotherapy, before every radiation session or every chemo session, they generally record this weight and all of the patient, weight, height, BP, pulse. So because of that, BMI is important. Over here only you will tell what is the ECOG of patient and or the Karnofsky curiosity of the patient. Whatever is being followed in your institute, please remember the same thing. It's not that कि आपको दोनों चीजें याद करनी है. In our setup, ECOG was followed, so I remember ECOG 0 to 5. Karnofsky मेरे को सिर्फ grading पता है कि 100 तक होता है. Details I don't remember. Same is with everybody. No one will point out to you कि तुमने पूरा एकदम याद क्यों नहीं किया. Tell him कि सर मेरे यहाँ पे Karnofsky use होते हैं, so I remember Karnofsky. And ECOG का full form you all know that Eastern Cooperative Oncology Group is there. Okay, so this can your question also. Eastern Cooperative Oncology Group. Okay, it's important. Okay, coming over ahead again. So examination में generally we'll start with the main examination, that is the oral cavity. In oral cavity, what all you have to see, the initial first thing is mouth opening. Okay, so why are you looking at the mouth opening? Mouth opening mein you can comment upon the trismus in case it's there. Grading of trismus they can ask you, and if you all remember, there was an image which was shared that was your trismus device. There was a screw kind of thing which was going into the mouth of the patient to increase the interincisor distance. Okay, then you have to comment upon the oral hygiene. Oral hygiene is fair, poor, nicotine stains are present or not, dental status, that the patient is edentulous or the teeth are intact. Then you have to comment upon the lips, the alveolus, okay, whether alveolus is involved or not. Guys, just a minute. Sorry for the disturbance, bhai. Okay, why alveolus is important? The involvement of alveolus in the oral cavity malignancy will change your treatment. Okay, whether the mandibulectomy has to be done or not, so that will be a decisive factor. So, जब आप the same thing that you will this is not important in the larynx setup because oral cavity में कुछ involvement नहीं होगा larynx में, but the same things when you will start in the oral cavity malignancy, so then all these things will become important. Okay, how is the anterior 2/3 of the tongue? Okay, so we'll discuss what all will be there in the tongue, how you will describe it. Larynx for generally it's normal, so you don't have to comment anything on this. What is this hard palate and how is this RMT? Okay, subsides of oral cavity is important. Okay, he'll ask you what are the subsides of oral cavity. Over here, same goes for the oropharynx. What are the subsides? That's important. That is base of tongue, tonsil, posterior pharyngeal wall, and in case any problem in the uvula, that you have to tell. After the oropharynx, then you have to comment upon the neck. How is the neck? In neck, whether there is any swelling present or whether this laryngeal crepitus is present or not. Okay, so this is important. So because if the malignancy has spread to the prevertebral space, so that crepitus will not be present. So you'll say laryngeal crepitus is negative, and your malignancy will be advanced. Okay, and then you'll come and give the findings of ideal. Okay, so normally they provide with everything, but carry all your instruments with you. So because of this thing itself, like doing that ideal in that exam setting is a difficult issue. Okay, so generally these kind of cases are avoided. Okay, so that was my take. I have not seen in the last 5 years that कि इस तरीके से case commonly दिया हो. Otherwise, they'll tell you the findings also. Okay, so now over here in ideal, you have to what all things that you have to remember. See, in today's setting, doing an ideal is quite obsolete thing. Okay, everybody does that endoscopy for the patient, but for the exam purpose, you should know the technique of ideal. What do you see in ideal? They might नहीं. जब आप exam में लिखेंगे तो image भी आपको बनाना है. The image of ideal has to be made. Over here, similar things will be there for the posterior rhinoscopy mirror. Okay. So if you guys have any difficulty over here, so please let me know कि ये question में doubt आ रहा है करके. ठीक है. So coming to the diagnosis. So what all you will find over here is in the ideal, that is this much into this much centimeter swelling. Like let us take 3 into 2 centimeter. What kind of swelling that you are seeing, that you have to comment. Ulcerative, proliferative, whatever type of swelling. Generally it's ulcerative swelling. Or mass, you have to comment mass. If you are able to tell कहाँ से arise हो रहा है, fair enough, ठीक है. And involving, where all it's extending, that if you are able to comment to. And if it is overhanging, so you can tell it कि sir the mass is overhanging the vocal cords. I'm not able to see the interior entire vocal cord. Second thing which you have to comment is the mobility of vocal cords. And third thing which you have to cover is glottic chink. Okay. And over here only ki like if the entire hemilarynx is fixed, left side or right side depending upon the growth involved, if the hemilarynx is fixed, so what does it tell? It tells us that the paraglottic space has started being infiltrated, so it is like advanced disease. Okay, so over here now comes the basically how you have to start your viva. Okay, so we'll just speed up a bit ki how will you manage this case. How will you manage the case? So over here, I'll again request to you. ये जैसे ही बोलते हैं हम लोग का एक we have a fixed setup in mind. तुरंत will say कि sir will do a surgery for the patient. Please doctor, don't answer like this in the main exam. Then somebody asks you कि how will you manage this case? So tell sir, I would like to evaluate the patient further. Okay, I would like to evaluate the patient further. How will you like to evaluate? Sir, I would like to do a Hopkins endoscopy for the patient to confirm my findings. Then I would like to go for CECT. So over here, CT scan and MRI both have certain specific indications, and depends upon institution to institution what all we have taught. Like in our setup, what we used to do for buccal mucosa and for lateral border of tongue. For them, we used to do MRI, and for the remaining persons, we used to do CCT. Okay, so you should be able to defend yourself, whatever you are saying. Nothing is wrong, nothing is right. It's all about circumstances. Okay, so in what are the plus point about CT scan? This is like CT scan is commonly available. Okay, timings. Okay, and in the government setup, in the MRI, you will get a waiting of longer period. In CT scan, the waiting is less, and the third thing is cost. Obviously, cost. Okay, so all these three things generally in the practical world they all decide what we want to do. Okay, over here only he might ask you what is your opinion about doing PET CT over here. Okay, so it all depends upon what practice you have been following. Like I'll tell you, in our setup what we used to do was ki initially for the initial management nothing, Hopkins endoscopy, CCT, and after that we used to go for direct laryngoscopy, DLscopy. in DL-scopy you took biopsy, and the basis of biopsy the further treatment was planned. Okay, so TL, this question will be discussed in the total laryngectomy section. Over here another favorite question of ये Viva is कि in DL-scopy, ठीक है, why do you want to do DL-scopy? So in DL-scopy, one thing is that you want to see the extent of disease and whether you will be able to reconstruction के बिना काम चल सकता है, or you have to do reconstruction with certain flaps also. Okay, so that margin basically the head and neck surgeon takes that margin whether it's available to him or not. Okay, apart from him, they'll ask you what is the difference between a ideal and a direct laryngoscopy, that is DL-scopy. So you'll be another question which is very favorite of examiners is what are the hidden areas of larynx. So over here only you should be ready with this thing, that is infrahyoid epiglottis. Can somebody help me with this?
The tongue base, the epiglottic space,
Base of
anterior
commission. Anterior commission. Yes. And then cricoid region. Post-cricoid region. Yes. Pre-epiglottic space. And then comes your post-cricoid region. Almost we have covered all. Apart from that, there is
under surface of glottis.
Yes, bilkul. Under surface of your glottis, that is a subglottic region, and apex of your pyriform fossa might not be visible. Okay, so these are all your hidden areas of larynx. So just if he asks you, so tuck, you should go about it. Okay, coming to guidelines which you have to quote over there, these are your AGCC 8th edition and NCCN guidelines. Normally what आपका पहला चीज है NCCN का full form क्या है? That is your National Comprehensive Cancer Network. This is what most of the government hospitals in India follow. These are basically framed by the Tata Memorial Hospital itself, but the name is given as NCCN. And second is what are the changes in AGCC that we have continuously kept on hammering you with this thing. One change will be there in the CA tongue का जो staging है वो change किया है, depth of invasion has been included, and second thing has been the changes in the thyroid malignancy. Okay. So coming to again another question box. This is one of the very favorite question of the examiners, and most of the time the questions will be asked from this separate section. As I keep on saying, जैसे skull base से question आता ही आता है, वैसे there is something called as rehab after TL. So from यहाँ से question आपको पूछा ही जाएगा. Even this is more important than total laryngectomy itself. Okay. So you should remember कि for the rehab, what all are the important points. Basically for the speech per se, what is esophageal speech, what is the what are valves that you can use, what is the TP that you are using, what is primary TP, what is secondary TP, what are the methods of changing the TP, that all you should be familiar with. Okay, staging, no doubt we have, it's important, included it in the further settings. So coming to this total laryngectomy, guys, it's very important question for you, both for OSCE, both for Viva. Okay, so how you could divide it? First is indications, then comes the steps, then comes the complications, और चौथा है आपका rehab. So these are the 4 subsets कि जहाँ से question पूछे जाएंगे. So coming to the indications. So as soon as somebody asks you what are the indications of total laryngectomy, kindly don't jump upon कि sir CA larynx is the indication. Okay, so please try to divide it. If your physiology is impaired, like if the patient is having chronic aspiration, this is one indication. Then involvement or spread, what T3 के लिए तो standard of choice है ही आपका, और T4 also people do it, or cartilage is okay. And in miscellaneous, there is some recurrence, you are using some conservative method, some radiation wasn't used, something like that, but the cancer has recurred. So that in that scenario also total laryngectomy is used. Okay. Coming to the steps, I'll share the PDF of steps with you. Important is the Gluck Sorensen incision over here, and ये हो गया. ये steps, the whole PDF around जो आपके 8 to 10 steps हैं, that I'll share with you guys. Please go through it. Coming to the complications, The questions which can be asked is what complications can you expect? So always answer in the separate part. You can either answer, sir, intra-op complication or the post-op complications, or you can answer as at early complications or late complications. Okay, a very, I'll say it's a very stupid doubt. I'll just ask you, does somebody of you think that RLN injury is a complication of total laryngectomy? कोई है? Just raise the hand. हाँ, है ना? So that's what I wanted to tell you guys. This was ये मेरा बहुत गंदा डाउट था, but क्या हुआ? Okay. This was my very poor doubt, but guys, let me tell you, I'll again write it. RLN injury is not a complication of TN. ठीक है? In the larynx, we are removing this total laryngectomy. अब पूरा larynx ही उड़ा दिया. And so RLN बचे ना बचे रहे ना रहे उससे कोई फर्क नहीं पड़ता है. ठीक है? So please don't answer this thing. This is very like a trap for us. Okay, so you can answer it in multiple other ways that we have described. The important ones being, one is your PCF, that is your pharyngocutaneous fistula, नीचे डाला हुआ है, ठीक है? This pharyngocutaneous fistula that develops within 7 to 10 days of surgery. The treatment initially is compression dressing, and this lasts up to 40 days of, if conservative management is up to 40 days, and after that, like surgical management can be done. Second is your stomal recurrence. There are multiple other things. I am looking at the answer from the exam point of view. Okay, stomal recurrence, that the cancer occurs at the stoma. Okay, so यहाँ पे आपको एक classification का नाम याद रखना है. The name of that classification is
Susan's
Atiya and Susan's classification. Okay, so please remember this name, even the details also. This is a potential question, important. Okay. So we have seen this thing. What is this? Okay, so this is basically the important questions are mentioned over here. GNFA question, generally it comes. CSF anuria is a very important topic. Chiroplasty is generally asked. Type 1 most important. Then comes your rehab. Okay, rehab after TL is very important. And ये तो आप लोगों ने पढ़ रखा है. Over nothing over here. Let's come to the literature that needs to be quoted for your these type of answers. One is this. Okay, so over here, see, like please see at this point that the relative risk of this one, the relative risk of laryngeal cancer between smoker and non-smoker is 15.5 in men and 12.4 in men. So this will be your answer if the examiner asks you that how will you say why is smoking important? So you can quote this line, sir, in Scott Brown it's given that this is the relative risk, so which is obviously higher in smokers. So that is why smoking is important to you. Okay, then second question, when during the time of when he'll ask you why is alcohol and smoking both important, so at that time you have to say that sir, the combined use of tobacco and alcohol increases the risk of laryngeal cancer by 50% over the risk. So agar see, believe me, like giving you during the Viva session, if you quote certain figures now, so it's always beneficial to your overall score. Even if one or two data you quote, sir, in this literature, in this article, in this book, it is written like this, so it's always helpful to you. Okay, so one is this is important. Second, again over here only, in laryngeal carcinoma, the risk in smokers and drinkers is this much, up to 177 times the risk of non-smoker and non-drinker. So again, the same point, why is smoking important? So that you should answer over here. Subsides of your larynx are given over here. Please learn. Now, these are the subsides: supraglottis, glottis, and subglottis. These are basically the involvement T1, T2, T3. You have to learn. L, this stage remains normal. So end staging है, this will be the same for everything. Every cancer end staging is same except for your nasopharyngeal carcinoma and thyroid carcinoma. This itself is a viva question कि end staging बताओ क्या होता है, and then they'll ask you कि भैया अलग किस में होता है. तो अलग वाला the different staging that you have to remember. These are basically your thyroid and the nasopharyngeal carcinoma. Okay, synergistic wala we'll see in the anything left? Nothing. See, the synergistic one I've included in the oral cavity. So let's start this oral cavity also. It has been little longer class. Please give me 15 minutes more time. We'll finish it. Okay, so coming to this oral cavity session. In the oral cavity, the patient will again come to you. Over here, the presenting complaint will be different. What will be the presenting complaint in a oral cavity patient? This will generally be a non-healing ulcer. Okay, so you have to start with again. A 30-year-old female came with complaints of non-healing ulcer over her left lateral border of tongue for the last 6 months, which was initially 1 into 1 centimeter in size and has progressed to present size of 3 into 2 centimeter. Okay. Now over here you have to mention the other things, whether there is any pain associated with it, whether there is any bleeding associated with the ulcer, whether there is any same purana wala apna dysphagia, dysphonia, whether there is any cough, there is any hemoptysis. Okay, so the main history remains the same. The presenting complaint will change and the same answers will change. Okay, and yoga. Then history of sharp tooth, you have to bring it out. This is an important history in the oral cavity cancers. Okay, in past history, similarly you have to answer. So there is no history of any previous medical or surgical illnesses. In personal, same discussion that was previously, smoking and alcohol पे जाना है आपको. Mention the pack years, how you calculate the pack years, that is important. Then comes the family history. If there is any cancer in the family, you have to mention. And then comes the treatment history, whether any treatments you have taken till now or not. Okay, so you will be asked to summarize your case. Okay, and the diagnosis. So diagnosis, how you'll make about the diagnosis is, it's a 30-year-old female, 30-year-old male female came with complaints of ulcerative. She's a case of ulcerative growth, left lateral border of tongue, this centimeter of size, probably malignant. And as soon as you'll say, sir, probably malignant, then the same questions will be bombarded. That why do you say the growth is malignant? Why do you say the growth is benign? Okay. So let's see the viva answers, how you have to give. Okay, so one of the very favorite question that is being asked is, Doctor, tell me that you said that the patient is smoker for last this much years, and if the patient stops smoking 1 year, so what is his risk that that he'll not get any cancer? So this is the thing that you have to start over here. Sir, the risk of oral cavity is reduced by 30%. Please rectify it. ठीक है, याद करना ये. Risk of oral cavity is reduced by 30% in those who have discontinued for 1 to 9 years, and by 50% who have discontinued by more than 9 years. Like if he has left it for more than 9 years, so risk उसका 50% reduce हो गया, और 1 to 9 years में है, तो that bracket में the risk is reduced by 30%. So this is one thing that you have to remember. It is important. Okay. Now this is the thing which we were discussing earlier. The problem that is associated with alcohol. As soon as you will say synergistic, these are the points. 7 points that you have to answer. ठीक है? Sir, it acts as a solvent. Rightly said. Sir, it acts like the non-alcoholic constituents, that also has carcinogenic activity. The aldehyde which is formed, that is again problematic. The chronic alcohol use, this you have to remember. Basically, you have to ratify it, है ना? Don't leave it. Okay. So coming to all the syndromes that are associated over here, please remember it. This is important. One is Lee-Frommeni syndrome. I'll just highlight it. Lee-Frommeni syndrome 1, Fanconi's anemia 2, Bloom syndrome 3, ataxia telangiectasia 4. ये 4 तो एकदम याद करने ही कर दे, ठीक है? Okay. Again coming overhead, this is the staging which is given in Scott Brown. ठीक है? यहाँ पे like the important thing which was included is the depth of invasion. So please remember it. That is important to you. This can even be asked in a OSCE also. Okay, what is the staging of the this thing? Okay, another Viva question is what are the pre-malignant lesions of the oral cavity? We all know the important ones being leukoplakia, erythroplakia, and the submucous fibrosis. And then the second question comes: what is the rate of transformation that this leukoplakia the patient is having? What are the rates of transformation for it into being a malignant lesion? So in leukoplakia, again go through these things. Please let me know. Like, I don't know, these kind of technical glitches generally don't happen, but it can happen anytime. So it's always better to drop a message. Thank you, Dr. Apurva and Dr. Irfan, for putting the message. Otherwise, I would have completed, and afterwards, mein pata chalta ki aisa hua. Okay, so guys, over here, this question is important to you. This pre-malignant lesions of oral cavity in itself is an important question. Okay, so generally the important ones you have to answer: sir, leukoplakia, erythroplakia, and the submucous fibrosis. The second question which will be asked from here over is: what is the percentage of transmission of this pre-malignant lesion into the cancerous lesion? So these figures you have to remember. That is, in leukoplakia it is up to 2.9, and in erythroplakia is up to 50%. Okay, OMSF mein, like, I was not able to find any actual data till now. My class is okay now? You are getting it?
Yes, sir.
Yes, thank you so much. Okay, so moving ahead in this thing, another thing which is a very common question is: what are the 5 S of oral cancer? That is basically smoking, spirit, syphilis, spices, and sharp tooth. This similar one was one of the question in my Viva, not in the main exam, in some another exam. That the lady was around 35-year-old lady with the CA of like malignancy of her tongue. So this was the question that if she is not smoking, if she is not drinking, then what do you think can be the reason of her malignancy? So the answer over there was this septic teeth, that is basically the sharp teeth. Okay. So now comes the various, these are the screenshots of various articles over where multiple questions have been discussed. The first one being that, like I told you in the LARYNX section, that what are the pathways of cancer? How does this cigarette smoking causes cancer? So these are the 3 points that you have to answer. How the cigarette smoking causes cancer. Okay. Now, second thing, very common question in the smoking section that you will answer: what are the carcinogens in cigarette smoke that you know which will cause cancer? So nicotine, just don't stop after saying nicotine, sir, nicotine, and then you start looking at the sky. So these are the afterwards, that is the polycyclic aromatic hydrocarbons, nitrosamines, aromatic amines, aldehydes, and the hydrocarbons and the various metals which are present in the smoke. Okay. Now, again, these are the similar flowchart, that is the methylation pathway which is there, because of which cancer is caused. This is more of a theoretical question, I'll say. And again, these are the all the Viva questions that are accumulated at one place. That what are the etiology of C oral cavity? One is the tobacco, we all have discussed. Alcohol, we have discussed. These are points are important. Please go through it. Then comes the infection, the HPV, HIV, and then the simplex virus. Then the nutrition factors, that is important. After that, the sharp tooth we all know, genetic predisposition we know, what are the familial cancers we have discussed. ECOG it has been discussed. This is the full form, 12025 you know, and second name is Karnofsky score. Okay, this was like which we lost in between. Now over here, the anatomy of tongue is very important to you. Okay, let me write it over here. Red, your entire anatomy of tongue is important, because if in case this oral cavity lesion comes to you as an answer, as a question, tongue will be the most important specific organ that is particularly involved. Okay, so you should know the muscles of tongue, the nerve supply of tongue. So basically you have 4 pair of intrinsic muscle, that is superior longitudinal, inferior longitudinal, transverse, and vertical. And apart from that, there are extrinsic muscles which are basically 4: genioglossus, hyoglossus, styloglossus, and palatoglossus. And they have basically nerve supply. There is only one which have different nerve supply other than the hypoglossal. Okay, this is how I had remembered it during I'll not say anatomy days. Anatomy में तो कुछ भी याद नहीं था. Residency में I had remembered it. GH, that is girls hostel के सामने style मारो तो पलट जाएगी. तो पलट is basically different. तो यहाँ पे the nerve is different. That is your internal branch of your superior laryngeal nerve. बाकी सबका GH style, that is your hypoglossal nerve. Okay, so please remember it. This is your basic differentiation that between the anterior 2/3, posterior 1/3, and the posterior most, how the nerve supply is different. So this is the entire data about the tongue that is important. Okay, so this is the data which we were talking about. What is the leukoplakia transformation rate? This is important. Over here now there will be multiple important paragraphs. I'll just share it with you. Presentation, this we have discussed, that basically ulceration or the lump over the tongue, that is important. Okay, generally intraoral sonography is not done at most of the centers. In case आपके center में if it's being done, so you can quote it. Okay, now this is important. I have mentioned it point wise. This page is from Scott Brown itself. The first thing is what is compartmental approach that you use during the malignancy. Second question is second not question, basically the point. The monopolar cautery, that cutting is used in the initial mucosa and coagulation when you reach the muscle part too. And third thing is this. What benefits will you get from free flap reconstruction? So you should know that what all options do you have while reconstructing for the tongue, the things you have removed. Okay, 2. Number 3 is in the neck. In the neck, the most important question is what is the indication of neck dissection in CA tongue? Okay, so like we have mentioned it point wise, we'll just be discussing it. Second question is over here only, let's see. One is PORT. What is PORT? So PORT is basically post-operative radiotherapy. And second question which will be asked is what are the indications of post-operative radiotherapy? That is basically one is for the positive margins. Second is basically multiple cervical nodes and the extracapsular spread in the neck, or stage 3 and 4 in the stage 3 and 4 disease. Okay, and after the indication of this thing, one more thing I just wanted to tell you. Okay, this is the same slaughter and all hypothesis that is continued over here. Okay, now coming to these are the same points. These points are exactly the same in Stellan Marin and Scott Brown. You can go from any one of them. So these are the indications of neck dissection in CA oral cavity. That is basically over here only. I'll just mention one more point. Management of N0 neck. Okay, this is very important Viva question. Why it is very important? We'll just be seeing it in another 2 minutes. Okay, so let's finish this thing. That why all these things should be done. This is like bilateral neck dissection should be considered in the tumor that extend beyond the midline, and apart from that, this is the reason that elective neck dissection should be considered for tumor which is more than 3 to 4 centimeter thick, or tumor T1 tumor that demonstrate poor differentiation or poor histological features. Okay, so why was this N0 neck being discussed? Because of this lady, why the Cruz. So for our exam, Ileana De Cruz is not important. Dr. De Cruz is important. Okay, I know most of you would have read this article till now. In case you have not read this article, please go through it. We'll be sharing it to you. Otherwise, the gist of that entire article is given in this paragraph of Scott Brown. Initially, what used to happen was that in CA oral cavity, if the patient was not having any mets in the neck dissection was not done. Then came this thought process that even if the N0 neck is there, koi neck mein there is no node, still elective neck dissection is being done now. So why was this change done? This change was done because of Dr. De Cruz. He made 2 groups of patients in all of CA oral cavity, in which एक में elective surgery किया गया, एक में the patient were kept under observation, regular follow-up, and in case neck nodes were there, so therapeutic surgery was done. So let us read this thing that D. Cruz had kept around 500 patients, 245 in the elective surgery group and 255 in the therapeutic surgery group, and there was a follow-up of around three years. And elective neck dissection people had a improved rate of overall survival. Okay, so that's why this De Cruz et al. Thing is important for us. Please go through it. Okay, so indication of radiotherapy we have seen over here. Okay, now there is certain treatment methodologies which are important to you. One is the Weiser approach. This Weiser approach, the data is from Stelmaren, and after this thing, three things of these osteotomies, they have been multiple times, they have been asked to you, what are the steps oblique places of osteotomy in the maxillectomy, in rhinoplasty, and in mandible. Okay, so maxilla wala we have discussed it in our osteology section, and this is for the mandible wala section. Please go through it. Involvement of mandible is important in C-oral cavity, so that's why whenever you are giving the examination finding of oral cavity mein, so you have to mention whether the alveolus is involved, whether it's not involved, what is the exact involvement in the mandible region. Okay, another question that you have to read about in neck dissection. One, what structures do you remove in each, and what are the incisions that you have to follow? Okay, next Viva question is this. Why do you remove IJV? Why do you remove sternocleidomastoid? And why do you remove SAN? So basically, most of the lymph nodes are around IJV, and so that's why you have to remove IJV to and SCM you have to remove to have the exposure basically, and this SAN basically divides the 2A and 2B. So that's why to clear 2B, this SAN has to be removed. For adequate clearance, you have to remove. Okay, so these 2-3 OSCEs are related to the same thing. The one thing is identify the procedure. I'll request to watch this video again on YouTube, because the same thing can be given to you as a video based question, also as a GIF based question. So image is one thing, but seeing it in a video is entirely different thing. So this is basically your fiber optic endoscopy evaluation of swallowing, and there is a certain modification of this in which this is replaced with this is also added with sensory testing. The F is replaced with flexible, and this is actually sensory testing. Okay, over here only two things over here. Okay, nothing. This video fluoroscopy is being regularly done in multiple places. So as the NBI is important to your larynx section, your endoscopy section in this VFS, and your barium swallow is also important over here. Okay. Then comes to another set of question, muscles of tongue. We have already seen the extrinsic and the intrinsic muscles divided. One question which can be extended further, one limit is what are the attachment of the question or attachment of the muscles of the tongue. How they can ask you? They can give you one image of a section. They can ask you what identify this muscle X and where is it attached. इस तरीके से पूछ सकते हैं. So over here, most important will be genoglossus. Genoglossus is called as the safety muscle of the tongue. Basically, it's a fan-shaped muscle. Let us see in this image. We'll be seeing these images in the end, okay? Images at the end of this PDF. I've included all the images. Okay, another question, same. What imaging will you do and why will you do? So imaging, basically, you have to see the extent of the lesion, whether there is any neck node involved, whether there is any distant mets involved. Okay, so you should know the difference between thickness and DOI, and this is given over here. And whatever you say, basically you should have a defense plan ready for this thing. Like अगर आप MRI बोल रहे हैं कि sir I will like to do, so basically MRI, there's scientific data to back up your thing that buccal mucosa and lateral border of tongue, the standard of care is MRI. If it's not available, then you can go for your CCT. In CCT also, the one question that is being asked is कि CCT कहाँ से कहाँ तक करोगे? One is from CCT base of skull to clavicle. If you want to do CCT base of skull to diaphragm, there can be a point from examiner. Doctor, why will you like to do this CCT from base of skull to diaphragm? So one thing you can support your answer, like suppose if the same question was asked to me, how would I have taken this thing? If sir, the patient has been a smoker for last 30-35 years, and there is a possibility that there might be any distant mets in the lungs, or there might be any other pathology in the lung per se. Okay, so that will be taken up if we do it till the diaphragm. So that's why I've included it till diaphragm. So you can defend it whatever way you like, but don't just blindly say it कि सर मैं यहाँ तक करूंगा, क्यों करूंगा पता नहीं, है ना? तो अगर ऐसा डाउट है तो you can stop your answer till clavicle only, कि sir I would like to do CCT base of skull till clavicle. Okay. So approaches we saw, there are two approaches, that is pull through approach and the visor approach. And okay, basically this question is from the TMC Viva. Why will you do MRI? So MRI basically helps us to plan our approach, one, and second is it helps us basically approach ki what type of reconstruction will we be doing it. Okay, surgery mein in case alveolus is involved, so if mandible anyway is involved, two things you can do, that is mandibulotomy can be done and pull through approach can be taken. Now over here, if the primary closure will be done, like if it's 1 centimeter, and अगर hemiglossectomy आपने किया है, so this can be your options which you have, and अगर total glossectomy कर रहे हैं तो PMMC can be one of the option available to you. This question has been asked once. We have seen it also. That specimen was given of maxillectomy with orbital exentration, and you were asked what surgery is being performed. What are the options of recon that you are having? Similar thing can be given over here also. Some surgical specimen can be given to you, and you will be asked what can be the indication of this surgery, or will you reconstruct this kind of surgery? Okay. Now, when is tracheostomy important? Basically, when there is involvement of genoglossus and when there is extensive resection. So generally, people do an elective tracheostomy first and then go for this surgery of tongue. And what are the indications for EUA, that is examination under anesthesia? Then you have to say, sir, there is when the patient is non-cooperative and there is 3D, you want to basically make a 3D mapping. Okay, and if we cannot get around the tumor, this is again a viva from your TMC. Okay, workup may you can plan EUA along with the DL scopy itself. Okay. Safety muscle of tongue, genoglossus we have seen, origin and insertion we have to see from the image. Okay, so these are the images this I took from CanHub section. I'll like you to focus on genoglossus first, and after that on all the muscles, because tongue being an important question, any one of them can be asked. It's not like only genoglossus can be asked. Okay, so please go through it. This is the important one, genoglossus. It's like a fan. It's spreading from one end to the other end. Okay, and that's why it's called the safety muscle, because it will prevent the blockage of your entire airway. Okay, this you have seen, and after this genoglossus, all the other images have been included. See, this kind of image can be given to you in the OSCE itself, and they will ask you, Dr. Sab, identify X1, what is its origin and insertion, and what is its nerve supply. Okay, so that's why you should be familiar with all the four muscles of the of your tongue. Okay, so this is your palatoglossus, and this is your hyoglossus. Okay, so over here, okay, so this was one more thing that was remaining in that feast thing. Nothing significant to this. DD of tongue mass. You can approach anyway. So it can be a benign mass, it can be an infectious mass. Infectious, what can be? TB can present to you, scarlet fever can present to you, syphilis can present to you, and then it can be malignancy. In malignancy, generally we deal with squamous cell carcinoma most of the time. Apart from that, leiomyosarcoma, rhabdomyosarcoma can be there, and idiopathic it can be a hairy tongue, it can be glossitis. Okay, so one last OSCE for you for today to break the sleep cycle. If these images are given to you, identify the disease. Yeah, finding what is being shown.
Mulberry teeth.
Mulberry molars. Okay, so these are mulberry molars, a triad which is associated with congenital syphilis. This kind of teeth can also be shown to you. ये जो Hutchinson's, इनको Hutchinson's teeth बोलते हैं. Interstitial keratitis and SNHL is seen. Okay, so SNHL भी देखते हैं, तो this is the triad which is seen in congenital syphilis. This is known as mulberry molars. I'll be sharing these things to you. Along with this, the videos of entire Viva discussion, जो एक घंटे के videos हैं from your TMC Tata Memorial Hospital, they are more of that formal kind, including the proper question and answer sessions. Please go through them once again. And in case of any problem, any difficulty, please let me know. Okay, over the next 3 weeks, abhi approximate 2 to 3 weeks we are having for the exam. We'll be discussing these daily around 10 to 20 OSCEs, important questions. Most of them have been discussed till now, but still it will be a revision for you, and it will be a stimulus that never stop studying, never feel that I have learned enough, I have studied enough. No, until your result is declared, don't think these things. Okay, and if you want any other topic or any other section to be covered in discussion, please let me know. As per the scheduled discussions, we have finished almost everything, and if something is left here and there, or you feel that these things required to be covered, so we will discuss it in a OSCE based format. And I'll request be ready for a mock test again. Go well with it, and it's okay with you, then in the first week of October also we can meet. But first week of October will be little bit dicey, that you will realize as soon as you enter that phase. Okay, second thing, again I'll like before we sign off for today, please make a note or copy or whatever you want, जहाँ पे अपने difficult topics keep on mentioning the difficult topics that I'm not able to remember thyroplasty type 1, तो लिख लिया वहाँ पे. तो ऐसे करके you will be having around 15, 20, 25 topics, and whenever you go to your exam center, उसके 48 hours पहले से पढ़ाई बंद हो जाती है. The exam, our brain starts shutting down. Okay, so that is the time when you will think now I don't know how to revise, what to study. So those 15-20 topics will be your savior that time. Please believe me, it will be your savior that time. You'll revise it, and you'll thank God when that thing is asked in the OSCE exam. Okay, and